Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from June 26th to July the 3rd. Here's the overview. On June 29th, the joint AHA, ACC, ESC, WHF published expert consensus document, the second universal definition of heart failure 2026. Major change includes LVEF classifications is simplified into three clinical actionable groups: heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and heart failure with improved ejection fraction. The first proposed universal etiology classification includes the following 14 pathogenic groups with specific examples: ischemic, hypertensive, valvular, arrhythmia-related, infiltrative, infective, inflammatory, toxic, heritable, pericardial, metabolic or nutritional, pregnancy-related, stress-induced, pulmonary or right-sided, congenital, high output, and idiopathic. A holistic framework on heart failure trajectories is introduced, distinguishing improvement, remission, and recovery. Once diagnosed, heart failure is considered permanent, even with clinical improvement. On June 29th, ASCO published therapy for stage 4 non-small cell lung cancer with driver alterations. ASCO Living Guideline version 2026.3.2. New recommendations include repotrectinib is added as a new first-line option for NTRK rearrangements alongside entrectinib and larotrectinib. It is a next-generation macrocyclic TRK ROS1 LKTK1 with enhanced CNS penetration and activity against solvent-front resistance mutations. Repotrectinib is now recommended for patients who have progressed on prior NTRK inhibitors. Zongertinib is recommended as first-line therapy for HER2 mutant non-small cell lung cancer, which is 2 to 4% of non-small cell lung cancer patients. Zongertinib and cevabetinib are added as options alongside trastuzumab deruxtecan for patients who have not received prior HER2 therapy, and they may be offered to patients who have progressed on trastuzumab deruxtecan with lower evidence level. On June 30th, American Gastroenterological Association published Clinical Practice Update Expert Review on Management of C. diff infection in adults. Valdoxamicin is clearly favored as first-line therapy based on lower recurrence rates. Vancomycin remains acceptable, and metronidazole is explicitly contraindicated except in fulminant disease. New FDA-approved microbiota therapies, Vost and Rubiota, are approved to prevent CDI regardless of the number of recurrences. Earlier use may be considered after initial infection or first recurrence in high-risk patients. Conventional fecal microbiota transplant, or FMT, with multi-dose via lower endoscopy is recommended for fulminant CDI not responding to therapy. Commercial products like Vost and Rubiota are not approved or studied for severe or fulminant CDI. Vancomycin suppression advised after recovery until outpatient FMT can be arranged. For first recurrence, more detailed guidance on taper pulse regimens. If initially on valdoxamicin, then start vancomycin taper pulse. If initially on vancomycin, then start valdoxamicin per standard or extend pulse protocol. Other considerations include Eslotoxumab is no longer commercially available. Using oral vancomycin during systemic antibiotics to prevent CDI is not recommended. Probiotics are ineffective for primary or secondary prevention, while prebiotics and diet like fruits, vegetables, or fiber are important to support microbiome restoration. If legitimate indication exists, discontinuation of PPI is not necessary based on largest RCT. June 30th, ACC published a scientific statement on antiplatelet therapy in the management of atherosclerotic cardiovascular disease. For primary prevention, aspirin is not beneficial in unselected populations. Benefit may have diminished due to widespread use of statins and other preventive strategies. Low-dose aspirin may be considered only in adults aged 40 to 70 years with high cardiovascular risk and low bleeding risk. For P212 inhibitor selection in ACS, prasugrel is recommended over ticagrelor in ACS patients undergoing PCI. Clopidogrel preferred in patients over 75 years for less bleeding with similar ischemic risk based on popular age trial. Guided or unguided de-escalation from ticagrelor or prasugrel to clopidogrel after 1 month is reasonable. Meta-analysis shows these strategies reduce major bleeding without increasing ischemic events. SMART 3 trial and HFSA 10-year follow-up show clopidogrel monotherapy may be superior to aspirin for long-term secondary prevention. For perioperative management, updated timing include clopidogrel and ticagrelor stop 5 days before surgery. Prasugrel stop 7 days before surgery. Platelet transfusion may reverse clopidogrel or prasugrel if given more than 6 hours after last dose. Limited effect on ticagrelor. About PPIs, omeprazole plus clopidogrel concerns not clinically proven in randomized trials. No significant difference in ischemic events between omeprazole and placebo with clopidogrel. PPI recommended for high bleeding risk patients on DAPT or oral anticoagulation. On June 30th, ACC published a scientific statement on direct oral anticoagulants in primary and secondary prevention of thrombotic events. New AF anticoagulation paradigm is now risk-based, not score-based. Estimated annual stroke risk over 2% per year leads to Class 1 recommendation for anticoagulation. In low to intermediate risk post-AF ablation patients maintaining sinus rhythm, discontinuation of anticoagulation at 1 year is reasonable based on OCEAN trial and ALONE AF trial. For subclinical AF, benefits of anticoagulants may exceed bleeding risk in patients with HFSA, a score over 4 or annual stroke risk about 2.2%. For VTE treatment, apixaban strategy is preferred over rivaroxaban for lower bleeding risk. For extended VTE treatment for 5 years, reduced dose DOAC, for example, apixaban 2.5 mg BID for 12 months in provoked PTE with persistent risk factors is superior to placebo in HiPro trial. Early DOAC initiation after stroke less than 4 days reduced 30-day composite outcome. OR is 0.7 according to Catalyst meta-analysis. 4 to 8 week waiting period is recommended before restarting anticoagulation after ICH. For cancer-associated thrombosis, after 6 months of anticoagulation, apixaban 2.5 mg BID was non-inferior to 5 mg BID for VTE prevention, with 25% relative bleeding reduction based on EPICAT trial. And DOACs generally preferred over low molecular weight heparin, with lower VTE recurrence and similar major bleeding risk. However, DOACs should not be used in rheumatic mitral stenosis with atrial fibrillation. DOACs are contraindicated in mechanical valves. On July 1st, ACG updated clinical guideline on colonic diverticulitis. New changes include strong recommendation against routine antibiotics for low-risk patients with acute uncomplicated diverticulitis. Colonoscopy is recommended for all patients with complicated diverticulitis and uncomplicated diverticulitis with alarm symptoms including weight loss, change in bowel habits, anemia, bloody stools, or persistent pain, or no current cancer screening. Dietary recommendations are now against avoidance of nuts, seeds, corn, or popcorn, and medications are not recommended for recurrence prevention. So no more mesalamine, rifaximin, or probiotics. Surgery is now no longer recommended based on number of episodes, but based on improving quality of life. July 2nd, the American Heart Association published a scientific statement on management of patients at risk of ischemic stroke with left ventricular systolic dysfunction in the absence of intracardiac thrombus. Left ventricular dysfunction is defined as left ventricular ejection fraction less than 40% or moderate to severe left ventricular wall motion abnormality. In primary prevention, anticoagulations reduces stroke but not net benefit due to higher hemorrhagic risk and mortality rate. In secondary prevention, rivaroxaban reduces stroke or SSE by 64% with hazard ratio of 0.36. In left ventricular dysfunction subgroup in Navigate-ACES trial. And apixaban reduced recurrent ischemic stroke by 76% with hazard ratio of 0.24 in left ventricular dysfunction subgroup in our Cardiol trial. For evaluation, ultrasound-enhancing agents or UEAs is now recommended for all patients with left ventricular ejection fraction less than 40% or wall motion abnormality extended from only one more than 2 segments not visualized in 2018 ASE guidelines. CMR preferred when TTE with UEA is non-diagnostic or clinical concern remains. Cardiac CAT scan can be an alternative when CMR unavailable or contraindicated. If anticoagulation selection, apixaban or rivaroxaban is preferred over warfarin. Move on to FDA news. On June 30th, the FDA approved allogeneic regulatory T-cell-based immunotherapy with hematopoietic stem and progenitor cell and T-cell VLDQ. The brand name is Tragzy, for use in matched donor hematopoietic stem cell transplantation with a myeloablative preparative regimen for hematopoietic and immunologic reconstruction and to improve chronic graft versus host disease free survival and the treatment of adults with hematological malignancies. The primary efficacy outcome measure was CGVHD-free survival, defined as the time from HSCT to death by any cause or moderate to severe CGVHD. The median CGFS was not estimated in Tragzy arm versus 7.3 months in control arm. Hazard ratio is 0.26. After a median follow-up of 8.48 months and 9.03 months respectively, the cumulative incidence of moderate to severe CGVHD estimate at 12 months was 12.6% for the Tragzy arm and 44% for the unmanipulated allograft control arm. Hazard ratio is 0.19. All 88 patients treated with Tragzy achieved a neutrophil count of 500 within 28 days of infusion. Of these, 53 patients had neutrophil counts above 500 and on 3 consecutive days, confirming neutrophil recovery within 28 days of infusion. The most common adverse reactions were mucositis, diarrhea, rash, viral infections, pathogen unspecified, abdominal pain, vomiting, nausea, bacterial infection, hemorrhage, acute GVHD, edema, and fungal infections. The prescribing information includes warnings and precautions for graft failure, GVHD, infusion reactions, secondary malignancies, and malignancies of donor origin, and transmission of infectious agents. That's all for today. See you next week.